So thank you very much, Len and Norm, for the opportunity to speak today. It's really a great pleasure to be able to talk with you about some of the cutting edge research that we're doing at the Vancouver Prostate Centre. So first things first, a little bit about who I am. So I'm a PhD student at the University of British Columbia, and I work in the lab of Dr. Alexander Wyatt. Alexander Wyatt is an assistant professor with the UBC Department of Urology. I began my PhD program in September 2018, and I work in this building here on the upper right-hand corner. So this is the Vancouver Prostate Centre, and we're located right next to Vancouver General Hospital in Vancouver. Now, our lab has quite a variegated research portfolio, and my research focuses more on some of the kind of computational aspects of this research. So developing software and algorithms to get a better understanding of prostate cancer biology. So if you're willing, I'm ready to go through the kind of the rest of my my presentation. If there's kind of no other questions. Good. Okay. So prior to getting into the research, there's kind of two brief pieces of background I want to touch upon first. So cancer is fundamentally a disease of the genome. And what I mean by this is that cancer is both caused and driven by mutations that are acquired in the DNA of normal cells. So what typically happens is that normal healthy cells will get a mutation to the DNA that enables that cell to divide more rapidly compared to other cells. And this kind of spurs a bit of a runaway process where the mutation causes the cell to be kind of less stable and it acquires more and more mutations through subsequent cell divisions. And eventually you get this total runaway process where you have uncontrolled proliferation. And this is what, in fact, cancer is. Now, these mutations can come from a variety of sources. You can inherit them from your parents. You can acquire these mutations from exposure to radiation or certain chemicals, or they can also happen spontaneously. So the machinery that's responsible for keeping your DNA intact sometimes makes mistakes, and occasionally these mistakes can happen in important genes and result in one of these kind of cancer-causing mutations. Now, there's kind of two types of mutations that we often care about in cancer research, and these are germline mutations and somatic mutations. So, as I mentioned, germline mutations are those that are inherited from your parents, and although they don't cause cancer, they can predispose you to getting cancer. And kind of one of the most common examples of this is a mutation in the gene called BRCA, BRCA1 or BRCA2, which you may have heard of. And specifically, this is mostly associated with breast cancer. That's in fact what BRCA stands for. It stands for breast cancer associated gene. The other side of this are somatic mutations. So these are mutations that are either acquired due to exposure to chemicals or happen spontaneously. But the key distinction is that these mutations cannot be passed on to your children. So these happen during, or these are acquired during a patient's lifespan. In prostate cancer, both types of these mutations are important. Germline mutations in particular are quite important in prostate cancer. And we know that people who have primary relatives with prostate cancer have a much higher risk of developing prostate cancer in their lifetime. And this is related to kind of this genetic link over the course of family generations. So mutations are a really important source of information in cancer research and indeed cancer treatment. But as a result of them arising, or at least as a result of the somatic mutations arising spontaneously, the mutations that drive each cancer are in fact different. So they're different between cancer type to cancer type. For example, prostate cancer mutations look very different from lung cancer mutations. But even within a specific cancer type, the mutations driving an individual patient's tumor tend to be very different. So this creates both a challenge, but also an opportunity. The challenge is that each patient's tumor is fundamentally biologically a little bit different, and it's something that we've really never seen before. But kind of the flip side of this is that this means that we're able to really precisely characterize individual patients' tumors and try and pair that patient with a therapy that they're most likely to benefit from, based off of the specific DNA mutations that we see in their tumor. So this is the concept of personalized cancer therapy, or precision medicine. So here we have a group of patients in gray, and we do tumor molecular profiling on these patients, and we're able to understand what patients, or rather what therapy might be most suitable for an individual patient, and then provide the patients that drug. So this is a little bit in contrast to how prostate cancer is currently managed. And although we have many drugs available for prostate cancer, these kind of clinical management strategies are relatively agnostic to an individual's unique biology. So personalized cancer therapy is kind of what our lab researches and is, I think, a really exciting kind of new paradigm for the treatment of not only prostate cancer, but for all cancers. So how do we use these DNA mutations to inform cancer care? The lab I work in with Dr. Alexander Wyatt, we specifically study metastatic prostate cancer. So this is cancer that has either recurred after localized treatment or is diagnosed as metastatic disease. And the first line therapy for metastatic cancer, or metastatic prostate cancer rather, is androgen deprivation therapy, so ADT. However, patients may eventually develop resistance to ADT, at which point their cancer is termed metastatic castration-resistant prostate cancer. Now, fortunately, in the last 6 or 7 years ago, a ton of new therapies have been approved for metastatic castration-resistant prostate cancer, including chemotherapies such as cabazitaxel, drugs like abiraterone and enzalutamide, and then many more experimental agents, such as, you may have heard of PARP inhibitors. And then drugs are constantly being approved for this disease state. So this is really exciting because we have a lot of different treatment options available for castrate-resistant prostate cancer. But as I said previously, a challenge is that it's difficult to know for sure which therapy will be best for an individual patient's tumor. And this is where the concept of biomarkers come in. So what is a biomarker? Well, a biomarker is any sort of biological molecule that can be found in the blood or in tissue. And it's essentially a clinical tool we can use to help understand a patient's disease and to understand how well they're responding to treatments, or whether in fact they will benefit from a given treatment. So the kind of canonical example in prostate cancer is, of course, PSA. So PSA is what we use for prostate cancer screening and diagnosis. And in later disease, we also use it to be able to monitor how well patients do on the therapy that they're given. So ultimately, this is a tool that clinicians can use to help really optimize cancer treatment for individual patients. Now, as I mentioned earlier, the mutations that we see in the tumor DNA can potentially be very informative. So this is a source of biomarker information that oncology is really moving towards incorporating into routine care. But a key challenge in prostate cancer is that it's actually very difficult to obtain tumor tissue in order to profile these mutations. So, for example, the tissue that you can get from a diagnostic biopsy might not actually be reflective of the current tumor state once a patient has progressed with metastatic disease. And this is, of course, because prostate cancer has a very long kind of natural history, and patients often go 5 or 10 years between their initial diagnosis and diagnosis of metastatic disease. So the biopsy might not actually reflect kind of the current tumor biology. Metastatic tissue biopsies, this is another source to obtain information about kind of the status of the tumor DNA. But a challenge is that metastatic biopsies are not part of standard of care. And this is for a couple of reasons. I mean, the first reason is that prostate cancer often metastasizes to the bone, and it's very invasive and associated with high morbidity to be able to actually perform tissue biopsies. So this is something that patients typically don't want to do, or might be actually clinically unfit to do. But there's also a technical reason as to why this is difficult, and it's that often the tissue that we get from metastatic biopsies, it's actually not suitable for analysis. So we can't really get the information we're looking for from this biopsy. Now, fortunately, in prostate cancer, there's a very convenient alternative, and this is something called plasma cell-free DNA, and this is what our lab studies. So all your cells, both your healthy cells and tumor cells, when they die, they shed a little bit of DNA into the bloodstream. So we can actually collect these DNA fragments from a routine blood test and look at these DNA fragments for mutations and try and basically use this to inform clinical care. So as I said, cell-free DNA is something that's present in everyone's bloodstream, including patients without cancer. However, in patients who do have cancer, their tumor is also going to be shedding these DNA fragments into the blood. And we call the proportion of cell-free DNA that comes from the tumor, we call it circulating tumor DNA. Now, circulating tumor DNA, as I said, the source of looking at mutations in the tumor genome. But one of the challenges of using circulating tumor DNA as a means to profile these tumors is that the amount of circulating tumor DNA we see in a patient is very variable. So patients can have anywhere between no circulating tumor DNA in their blood, or up to 80% or higher of the DNA that's in their blood actually comes from the tumor. And this is a little bit unpredictable, but it does seem to track with essentially patient prognosis and the volume of their disease. So patients who have a really good prognosis tend to have very low levels of tumor DNA in the blood, whereas patients with a poor prognosis might have a higher amount. So our lab, Dr. Alexander Wyatt, together with Dr. Kim Chi at BC Cancer, have began a biobanking program where patients who are diagnosed with metastatic prostate cancer and consent to this research, they provide us a blood sample. And from this minimally invasive blood sample, we can collect cell-free DNA as well as germline DNA. So the germline DNA is used to understand what mutations the patient may have inherited from their parents. And together with these kind of two sources of information, the somatic mutations and the germline mutations, we can sequence the DNA and try and understand how this impacts tumor biology and ultimately patient quality of life and response to therapy. One of the first studies that we did was to understand how well the circulating tumor DNA mutations actually reflects the tumor tissue itself. So my supervisor, Dr. Alexander Wyatt, led this seminal study where he compared the mutations that were picked up from the liquid biopsy, so ctDNA, and compared it to a metastatic tissue biopsy from the same patient. And each of these bars here represents a mutation. And you can see that the top and bottom look essentially identical. So in other words, this means that the mutations that we identify using our blood test are the same mutations that are present in the patient's tumor. So this sort of foundational kind of technical validation that this assay really does capture information that's clinically relevant. So what information does circulating tumor DNA actually provide us in the clinic? In order to talk about this, so I mentioned a little bit about biomarkers earlier. So in oncology, there's kind of two types of biomarkers that clinicians really care about. And these are called prognostic biomarkers and predictive biomarkers. Prognostic biomarkers, these are biomarkers that give us an overall impression of disease aggression. So an overall impression of how quickly the cancer is likely to progress, or conversely, how slowly it's likely to progress. And this is regardless of the particular treatment that a patient receives. On the other hand, we also have predictive biomarkers, and this is a huge focus now in oncology, is to identify these predictive biomarkers. These are biomarkers that indicate that the tumor is vulnerable to a specific therapy, or conversely, might be resistant to a specific therapy. So based on the presence or absence of these biomarkers in the tumor, we can actually kind of come up with a game plan in terms of what therapy the patient is most likely to benefit from, and pair them to therapies where there's a fundamental kind of biological link in that the patient is really likely to derive benefit from that therapy. So again, this is a really kind of exciting development in oncology that 10 years ago didn't exist. So I'd like to give a couple of examples of these different prognostic and predictive biomarkers that we can actually detect using our convenient blood test. So I mentioned that the amount of circulating tumor DNA that you have in the blood correlates with prognosis. And so this, in fact, is in of itself a prognostic biomarker. These here are called Kaplan-Meier curves. And so on the y-axis, it shows the percent of patients who are alive at a given time point. And you see that these two lines here in red, these are patients who had really high levels of ctDNA in the blood. And patients who have high levels of ctDNA tend to do more poorly compared to patients who have low or undetectable levels of circulating tumor DNA in the blood. And like I said, with the definition of a prognostic marker, this is independent of what sort of therapy they're receiving. So this is valuable information to know, to sort of get a sense of how challenging it might be to treat this particular patient's tumor. Because the amount of ctDNA in the blood is so closely connected to patient prognosis, we can actually use ctDNA levels in the blood to also monitor how well patients respond to a given therapy. So on the left-hand side, a patient was beginning treatment with abiraterone, and we collected ctDNA over several days to see kind of how it changed in response to therapy. And in this case on the left, the patient did not respond to the therapy, unfortunately, and we see this reflected in their ctDNA levels. So the ctDNA is rising over time, indicating that the therapy was not very effective in this patient. This is very useful information because within a short window of time after the patient begins therapy, we can quickly understand whether or not the therapy is actually going to benefit that patient. And if it appears to not benefit that patient, then we can quickly switch them onto another therapy that they're more likely to derive benefit from. And conversely, on the right-hand side, we kind of have the opposite example. So here a patient began therapy, and immediately after beginning therapy, we see that their circulating tumor DNA levels in the blood quickly drop to an undetectable level. So this rapid drop means that the patients really responded very well to therapy, and they're likely to derive long-term benefit from the therapy. So again, understanding this right up front in the days and weeks prior to beginning therapy is a really important tool for clinicians to make sure that they have indeed made an appropriate choice.
Cameron, on the
Sure.
previous slide, what were all the gray? There were a lot of gray lines on the left graph.
Good question. So this was a study that involved a lot of different patients. And so all the other gray lines are the ctDNA levels for different patients that were part of our study. And I just highlighted one of these patients here with the black line.
Okay.
Yeah. The final prognostic marker I'll talk about is one that our lab and others have been looking at very closely, which are DNA mutations in a gene called TP53. So in patients with metastatic prostate cancer, whether or not we detect one of these mutations gives us some important information about how well that patient is likely to do. So if we detect a TP53 mutation, typically this associates with poor prognosis. But conversely, on the other hand, if we fail to detect this mutation, it means that the patient is likely going to enjoy a much longer overall survival and is indeed going to be easier to treat. So again, this is useful information for doctors to know upfront. Now, I've spoken a lot about prognostic biomarkers, but ostensibly what's much more exciting in oncology is the concept of predictive biomarkers. And indeed, we're able to identify specific mutations in circulating tumor DNA that enable us to, with some degree of confidence, give patients therapy that they're really likely to strongly benefit from. So I have one really fascinating example of a patient that came through our clinic last year and that I helped profile with our blood test. So this was a patient with metastatic prostate cancer, and we collected a blood sample from him and identified a DNA mutation in a gene called AKT1. And this mutation is a little bit unique in that most mutations in cancer disrupt a gene's function. But this mutation was a bit different. It actually activated the gene and made it hyperactive relative to kind of normal physiological levels. The patient had a radical prostatectomy several years before this. And so we looked at his archival tumor tissue and found that this mutation, which is represented by this little green wedge on the upper right-hand corner of this circle, we found that this mutation was present throughout his prostate sample. When the patient underwent surgery for his localized disease, the surgeon, which is Dr. Martin Gleave, some of you might be familiar with, also identified several lymph nodes in the pelvis that also had evidence of kind of tumor lesions. And so we profiled the DNA of these lesions as well and found this AKT mutation in basically all of the tumor tissue we had available to us. So in other words, this mutation was present in high levels using our blood test and also in the patient's tumor tissue. So what this indicated to us is that this mutation was really fundamentally driving this patient's disease. The patient in question, by the time we had the blood sample available, he had already been treated with most standard of care therapies. So this here is a chart of PSA over time. And you can see that the patient was treated with docetaxel chemotherapy, enzalutamide, and radium-223, and really didn't derive too much benefit from any of these standard of care therapies. So this was reflective of the patient's really aggressive disease course. So on the basis of our blood test, finding this AKT1 mutation, the patient was given eventually compassionate access to a drug called an AKT inhibitor. This is a drug called ipatasertib. And even though the patient had really aggressive pre-treated disease, the patient benefited for nearly 8 months on the basis of this blood test and being treated with ipatasertib. And for late stage prostate cancer, this is a really kind of a remarkable amount of benefits. Again, given that the patient didn't really benefit from kind of the usual standard of care therapies. So collectively, what this anecdote suggests is that men with prostate cancer who have this particular mutation might be really good candidates for this drug called ipatasertib. And indeed, our lab and others are now testing this in clinical trials to see if we can get this approved for men with late-stage prostate cancer.
Cameron, before you leave, is that patient still alive? How many circulating blood tests, DNA blood tests were done, and how much would each one of those tests have cost?
It's a great question. So unfortunately, this patient has since passed away from their disease sometime last year. We were fortunate enough from a research perspective to have obtained, I think we have about 6 blood tests from him at different time points. The mutation was present in all of the different time points, and we actually use this to try and understand how the patient's disease kind of developed resistance to therapy. So that's another kind of research use of this blood test tool. The blood tests are relatively cheap compared to tissue biopsies. So typically a blood test will cost anywhere between $200 to $600, depending on kind of the precise parameters of the test.
Thank you.
So this brings me to my second to last point, which is that in order to actually use this blood test in the clinic, we have to do clinical trials to really establish the efficacy of this blood test. So most of the work I've presented previously is correlative in nature. So what this means is that we'll perform DNA sequencing on a patient's blood sample, and then we'll go backwards in time to look at how they might have responded to a certain therapy if they had the opportunity to take that. But in order to actually bring this to the clinic, we need to prospectively validate our test results. And this is kind of the other half of what our lab does. We also run a number of clinical trials where we use our blood test to determine which patients might be eligible for a specific experimental therapy. And then we can assign them to that clinical trial arm and see how well does this experimental therapy work, and can ctDNA in fact kind of optimally select patients who are really likely to benefit from that drug. So this is one example of a clinical trial that's ongoing out of our lab, where patients with late-stage prostate cancer provide us a blood sample for DNA testing. And then we have a number of different clinical trial arms where they'll receive a drug that's specifically tailored to the mutations that they have in their tumor DNA. And you'll see in yellow here that this gene I was just speaking about, AKT1, is excitingly one of the arms on our trial. So we'll have an opportunity to clinically test this and hopefully help bring this towards FDA or Health Canada approval. Now I have a final 2 slides on a slightly different topic. So I've spoken a lot about how this circulating tumor DNA test can be used to inform treatment decisions for men with prostate cancer. But I also want to mention kind of some of the more research-specific uses of circulating tumor DNA. And indeed, this is my current project at the moment. So in patients who develop metastatic prostate cancer, of course, the different metastatic lesions they all come from the same original tumor. But as the disease responds and resists the therapy, the different metastatic lesions actually develop slightly unique genetic alterations and indeed become a little bit of different populations over time. So what this means is that in patients who provide a metastatic tissue biopsy, this tissue biopsy actually might miss tumor populations that are clinically relevant. Now, I mentioned earlier that in terms of informing clinical care, metastatic biopsies are not very common, but it's still a very common research tool to try and understand features of tumor biology that might eventually become clinically relevant. So this kind of presents a natural question, which is, can we use circulating tumor DNA to better characterize the tumor genetic diversity in a patient's cancer, given that circulating tumor DNA is kind of the aggregate of all tumor cells that are shedding DNA into the blood. And so you can see in this cartoon here that in this hypothetical patient, the metastatic tissue biopsy of this yellow tumor here, it might only show kind of one tumor population, whereas the circulating tumor DNA might actually show a bit of all of the different lesions that are shedding DNA into the blood. So one of the things I'm trying to work on is develop a computational algorithm that tries to understand how many unique tumor populations are present in a patient's body. And the goal of this is to better understand biological complexity at the individual or at the level of individual patients. And we hope that this will eventually be informative in the clinic. And for example, it could be the case that patients with a really biologically complex tumor might have a higher probability of having upfront resistance mechanisms. So this might be actually a useful prognostic marker to later incorporate into clinical management strategies. So in summary, cancer is ultimately driven by mutations in the DNA, and we can detect these mutations using a simple blood test. The amount of circulating tumor DNA that we see in the blood is a useful source of prognostic information, as are specific mutations that we see in the tumor DNA. And then most excitingly, some of the mutations that we may pick up using our blood test might actually suggest a patient's disease is really vulnerable to specific therapies. So we can use this to give a patient a therapy that they're most likely to really benefit from, and actually really cater their clinical management to their specific individual disease. And so this is kind of the exciting new paradigm of clinical oncology, which is using these DNA predictive biomarkers to help inform treatment. Finally, I would like to thank all of the players involved in this. I mean, clinical research is a huge team effort, and there's many people to thank, including my supervisor, Dr. Alexander Wyatt, and our team, our collaborators at BC Cancer, and then, of course, most importantly, all the patients and their families who are willing to donate their time and data to help make this research possible. I feel really privileged to be able to work in this space and really make kind of concrete leaps or advancements in how we treat patients. And it's all thanks to those that are willing to participate in clinical trials and our blood test program at the Vancouver Prostate Centre. So with that, thank you for your attention, and I'm happy to answer any questions you might have.
So is there anyone who has a question?
I have a bunch of them, but
I'm sure
Frank,
you have, Richard.
Frank put up his hand first. So Frank, why don't you go ahead first?
Okay, I guess the first question is, we have heard of a circulating tumor cell or the liquid biopsy in the early days too. And one of the problems, it seemed to me, was that by the time you could start to measure circulating tumor cells in the blood, the person's cancer was starting to become an obvious problem to them. Has your sensitivity gotten better so that you can, the higher the sensitivity, the earlier on in the process, you'll be able to help the patient? How's that going?
That's an excellent question. So you're totally right in that circulating tumor DNA, or the so-called liquid biopsy, in the early stages, it was most effective for patients with really advanced disease. But as the technology improves over time, the kind of spectrum of disease where this test might be useful is broadening. So there's a lot of research coming out of both our lab and others that are using circulating tumor DNA in very early stages of cancer to, again, help inform treatment decisions in a way that's specific to the patient's disease. So this is indeed kind of the direction that this blood test is going, is earlier in disease.
Follow-on question, do you know what PSA level somebody has before you start to see circulating tumor cells?
Yeah, so it varies between patients, but typically the circulating tumor DNA is easiest to detect once a patient has developed what's called castration-resistant prostate cancer. So castration-resistant prostate cancer is diagnosed when we see a rise in PSA despite the patient still being treated with ADT. And so this can actually range from a PSA of 1 or 2 to up to 10 or higher. So it really varies between patients. Now, in the earlier disease setting, it's a little bit less clear how circulating tumor DNA levels correlate with PSA measurements. So I think that's an ongoing kind of area of research, since it would be very useful to know when to trigger this ctDNA blood testing based off of PSA levels.
Okay, thank you. So I guess the answer is greater than 1.0 is a possibility of getting a circulating tumor blood biopsy to work.
I would say, yeah, with our current sensitivity. But
Okay.
on the other hand, in other cancers, people are exploring circulating tumor DNA actually as a way to diagnose the cancer. So in principle, we do have sensitivity down to a much lower level, but it requires kind of a different type of assay. And the information that we get from that might not be as useful in terms of understanding which therapies to give to a specific patient. So more useful for trying to just detect the presence of cancer. And of course, in prostate cancer, PSA does a really good job of that. So I think circulating tumor DNA is kind of less likely to supplant PSA in the earliest of disease setting.
Okay,
Wow.
thank you.
Richard, you had a question. We'll go back to Don after Richard.
Okay, well, I have 2 comments and then a complicated question. First of all, my first comment is that was the best lecture I've ever heard on personalized DNA diagnostics for prostate cancer. So thank you, it was excellent. A small comment before I get to my complicated question was at the beginning when you talked about the nature and the causes of somatic mutations. You distinguished those that are due to radiation and toxic chemicals from those that are just spontaneous. But for the ones that are just spontaneous, how would you know that a cosmic ray hadn't just come through and disrupted the DNA and would not have left you any radioactive trace to know that? So I don't know how you could make that distinction.
So that's a great question. And the simple answer is that oftentimes we don't know.
Yeah.
So you're totally right in that, yeah, a cosmic ray could have.
I use that because people ask, "Wait, I know how do I get cancer? What are the causes?" I said, "There's cosmic rays all the time, so we have to consider that." Okay, so here's my complicated question: when you have somatic mutations, the mutations themselves present as a potential phenotype, and one of the phenotypes might be their potential to migrate. So one might imagine that we can be looking for mutations that are indicative, prognostic of mutagenesis itself, and also migration, metastasizing itself. And I'm wondering whether looking at this stuff early, one of the things one might want to be able to do eventually is to biopsy the localized prostate cancer tumor when the disease is still localized, and be able to say, you've got these mutations. These mutations not only are likely to migrate, to be metastatic, but they are more likely to metastasize to bone than lymph node. And therefore, we might want to be able to treat it more effectively with radium-223 than we might be with lutetium, because we can't go after soft tissue. And we know that for the patients, it is a big difference whether they're getting soft tissue and lymph node metastases versus bone metastases only. So the first question is, are any of these mutations themselves linked and not already to the migrating capability of the cells? And one of the other phenotypes itself is the propensity to shed DNA into the bloodstream. So one could imagine that a somatic mutation may lead to greater or less presence of the genes within the bloodstream. So do we know anything about that? Do we know whether any of these genes increase metastatic capability, are specific to where the metastases might go, and are specific to the propensity to shed DNA itself?
So that's a super insightful question, and I think you've hit the nail on the head in that this is a very active kind of area of research that it'd be very important to be able to uncover and predict in advance kind of what the tumor phenotype is going to look like. And so I'm pleased to report that there are actually some kind of exciting developments in this space for prostate cancer. The first that you mentioned, looking for mutations that might increase so-called metastatic potential. So I know there is some work that's suggesting that there may be some particular genes that are very responsible for enabling metastases. And so if they're inactivated, that might really increase the probability of the tumor kind of reaching that kind of threshold where they can escape the primary prostates and move to kind of other regions of the body. But I think another equally important kind of side of this research is not only understanding what mutations are responsible for that process, but also why certain organs are more likely to develop metastases than other organs. And a lot of this comes down to what's called the tumor microenvironment. So kind of what the local population of cells looks like in a given organ, and how that creates either an environment that's really conducive for metastatic growth or really repressive. And in prostate cancer, it seems like the bone microenvironment is really particularly conducive to the growth of metastases. So there's actually a postdoctoral fellow in my lab who's trying to determine if we were able to profile actually like the bone marrow of patients prior to them to getting metastatic cancer, based off of what the bone marrow looks like, can we predict what's the probability of them eventually getting a bone metastasis versus, say, a liver metastasis? So kind of both of those are, I think, important avenues of research.
Who is doing that?
That's Dr. Nicolette Fonseca, second to last on the slide here.
Oh.
She's an immunology postdoc in our lab.
Neat.
Yeah.
What about the shedding into the bloodstream? Anybody?
So the shedding's also a really good question. And there is some evidence that, again, mutations in certain genes might correlate with a higher degree of shedding. So to get a little bit technical for a moment, mutations in genes that are responsible for the cell cycle often can create kind of a higher degree of cell turnover. So the cell progresses through the cell cycle much faster because of these mutations, and is able to shed DNA more quickly. So there is some evidence to suggest that as well. And then the very final thing I'll mention is that we also have very good evidence in prostate cancer that mutations in certain genes called DNA damage repair genes are proving to be really important for what sort of phenotype the tumor has. And so it looks like you'll have someone be speaking on this, Dr. Lucia Nappi, who we also collaborate with. She might be talking at the next meeting, but not to spoil her talk, but mutations in these genes basically enable the tumor to become even more genetically unstable. So to rapidly acquire more mutations that increase the probability of it, getting mutations to enable it to escape the primary tumor sites or metastasize to specific organs. So it kind of just increases the probability of the tumor being much more aggressive. So this is something that our lab has characterized also pretty closely using circulating tumor DNA.
Thank you. That was brilliant. This is patronizing a bit, but I'd be grateful if you'd tell Alex that I thought you gave a great talk.
Oh, thank you very much. I'm really pleased to hear that.
Send that note too.
Okay, thanks.
Don Nisho, you had a question.
I did, but following Richard, I feel totally inadequate because I don't have any medical terms or scientific terms. My question, and you partially answered this when you replied to Frank, you're talking about people with metastatic cancer, what about people like myself who are at early stages and on active surveillance? Is there any advantage to getting DNA analysis and trying to identify whether I have the propensity for high-grade cancer or not? And the reason I ask is I've heard, particularly in the US, a lot of patients who are on active surveillance in the US say, yes, get the, the BRCA or other DNA testing, but any oncologists or urologists that I've talked to in British Columbia say, nah, it's not necessary.
Yeah.
And how would it change what you're doing anyway?
So also a great question. I think, yeah, as I mentioned earlier, circulating tumor DNA so far appears to be most useful in patients who have more advanced disease, because we'll have a higher quantity of tumor DNA to analyze. So it's a little bit easier to really precisely understand the alterations that are present in a given tumor. But conversely, as the testing technology improves, we can use this test earlier and earlier in disease state. And indeed, another thing that's being tested, not so much by our lab, but by others, is whether we can use circulating tumor DNA, kind of analogous to how we use PSA during active surveillance, to see whether the circulating tumor DNA levels, if they begin to go up, whether that's indicative of the tumor starting to progress or become more active. So that's one use of ctDNA in an earlier setting. I should mention though that this is not yet implemented in the clinic. So this is very much still an experimental kind of use of circulating tumor DNA. But the other thing that you mentioned is using ctDNA tests to identify, for example, mutations in the BRCA gene or other genes. And because we know that mutations in these genes can be used to identify therapies that patients are likely to benefit from. So for BRCA2, you may have heard of PARP inhibitors as the particular kind of drug of choice if a patient's tumor harbors that mutation. I'm not a physician, but my best guess is that the reason why your physician is maybe hesitant to do one of these genetic tests is that typically they're only performed in patients who have like high risk disease features. So for example, high PSA or high Gleason score, because we know that if there's a mutation in one of these genes, it causes this really aggressive phenotype. So unless we have evidence to suggest that this phenotype already exists, then current practice doesn't really typically use testing since it's likely to return a negative result. But that's something that's slowly changing more quickly in the US than it is in Canada. But if it's something that you're particularly interested in or think might be helpful, it's certainly worth, I think, bringing up with your doctor again. Again, a lot of this is research use only, but there are a couple of clinical tests that are available for this kind of early disease setting.
May I offer, I would like to offer a little comment, if that's okay,
Sure.
on Don's question. Don, I'm both an American and a Canadian, and I watch a lot of the chat list discussions. The question you always have to ask about any diagnostic test is, would it change treatment? And if it's not going to change treatment, then why have the test? But what happens in the United States is people feel that if there isn't a treatment, then they pay for the diagnosis, at least they're getting something done. I mean, I'm amused by this because in the days of George Washington, they bled people to lower blood pressure. So phlebotomy was therapeutic. Now you have people who just want a blood test no matter what. So diagnostics themselves have become therapeutic. And you're in great shape. Your PSA is well controlled. I would stand by the Canadian model. If it's not going to change treatment, then why bother to pay for the test? But in the Americans, if they can have got the money, they think something's got to be better if they spend the money on their healthcare. And I think there's a fundamental difference of the Canadian and American model here. Anyway, I'm starting a discussion. It's Cameron's talk, but at this point, the simplified answer is, if we're not going to change treatment, why bother to go for the diagnosis?
You have further question, Don?
Pardon me?
You have a further question?
No.
Oh, I have a comment or a question, I guess. It's my understanding that if you have the BRCA2 gene, that the progression of any prostate cancer is likely to be fairly rapid. In other words, your PSA rate of rise will be fairly quick. The doubling time will be shorter than those people who do not have the BRCA2. Is that right?
That's exactly correct. So if we find a mutation in the BRCA2 gene, typically that's in the lingo that we talked about during the presentation, that would be called a poor prognostic marker. So patients who have this particular tumor mutation will have a much faster PSA doubling time if we're talking about earlier disease, or in general, just a much faster PSA rise. And so that's why it's important to know whether a patient has this mutation, because it gives us information about their prognosis, so how well they're likely to do kind of in general, regardless of what therapy they have. But it's also one of these so-called actionable mutations where we actually have a therapy that specifically targets cells that have this mutation. And in 2020, 2 of these different types of drugs called PARP inhibitors were actually FDA approved and Health Canada approved. So we now have kind of precision treatment options for patients who have these particular mutations.
So really, as a summary, watching doubling time becomes really, really important for all newly diagnosed patients.
Exactly. Yeah, doubling time is something that's certainly worth keeping a close eye on, really regardless of what underlying mutations are in a patient's tumor. This is another kind of clinical biomarker that is really informative to help monitor disease and understand whether it's potentially progressing or getting worse.
The other comment I'd like to make is I'm actually delighted that the analysis capability that you people have developed over the last even as 2 years, I think has really improved remarkably. And you may want to comment on that.
Yeah, it's amazing how quickly this field moves and how rapidly this technology is improving. I wish I had a slide to this effect, but our sensitivity and specificity, so these are kind of the 2 technical parameters we really care about, are improving kind of year after year. And what this means is that it opens up many new avenues for using circulating tumor DNA in the clinic. And now we're trying to actually test a lot of these potential applications in clinical trials, like Canada-wide and international clinical trials, and to try and get this test as a part of kind of routine clinical management, because it's state-of-the-art technology and really does have the capacity to make a pretty big difference. So it's such a privilege to be able to work in this space and actually see our research findings like quickly get translated to the clinic. I don't know of many other fields where there's this kind of quick turnaround. So it is really exciting.
Marvelous. Any other questions? Anybody have any other questions? Oh yes, John. John, you have a question?
Yes, I'm just wondering, we're talking about prostate cancer, but I often, because of the high rate of breast cancer, I'm just wondering, this research you're working on, is there an application for breast cancer, and what kind of biomarkers do women have to rely on? I mean, men, it's PSA, but what kind of biomarkers do women have to rely on to be tested?
So that's a great question. So circulating, I guess to answer your first question, circulating tumor DNA is not unique to prostate cancer. So most cancers do shed a little bit of their tumor DNA into the blood. And so we can analyze this through our blood test. Breast cancer is certainly one of these cancers where it seems to shed a fairly high amount of circulating tumor DNA. And so there's a lot of also research going on, trying to understand how to leverage circulating tumor DNA in breast cancer to improve treatment outcomes. But you hit upon an interesting point in kind of an interesting difference between breast and prostate cancer, in that breast cancer is a little bit more challenging to monitor because you don't have an equivalent to PSA in breast cancer. So in some ways, prostate cancer, it's almost kind of a fortunate accident that there exists this molecule PSA, because it's a truly indispensable tool for monitoring disease. And breast cancer doesn't quite have that. So circulating tumor DNA levels actually might be a potentially effective means of monitoring breast cancer, kind of like how we use PSA in prostate cancer. So that's certainly one potential use of ctDNA. The second is, you mentioned kind of what specific DNA biomarkers do we typically look for in breast cancer. So I think the most exciting one is mutations in this gene called BRCA1 or BRCA2. And this is kind of an interesting parallel between prostate and breast cancers, in that both these very different cancers can actually be driven by the same mutation in the same gene. And if we see that mutation in breast cancer or prostate cancer, it has sort of the same prognostic implications. So it means that the patient will probably have more aggressive disease. But more encouragingly, it also means that the patient is really likely to benefit from one of these drugs called a PARP inhibitor. So that's probably the most kind of exciting development in breast and prostate cancer, for that matter as well. But breast cancer circulating tumor DNA is an entirely different field, and I know there's a lot of exciting work trying to, again, develop predictive biomarkers to help optimize treatment for breast cancer.
Thank you very much, Cameron.
I'd like to follow up on Richard's.
Frank?
Yeah, I think early on, Richard asked how you can tell somatic, spontaneous, or from other actual effects. And the way you would do that is you look at the type of cancer. So if somebody has like smoked cigarettes, they typically have like 10 times the chance of dying. If they have asbestos particles in their lung, then pretty much they'll only get that type of cancer. Or if you blast people either on purpose or accidentally with radiation, you can see the cancer rise. So that's how you'd know if it's spontaneous or caused by some outside effect.
Frank, not really. That would tell you what the probability is of it being due to a toxin. But if you have a mutation, it might not have metastasized, but you simply get a abnormal chromosome break, whether it proliferates as cancer or not. You don't know what caused that single DNA break. And that's what I was talking about. I was talking about the basic at the molecular level, not in terms of disease progression. So we're talking about two different things.
Well, no,
it
follows back to the molecular level, though. Anyways, this is a Richard Frank comment.
Right.
I would be happy to jump in on
Please
this.
do.
So I mean, both of you are right in that ultimately at the level of single mutations, unless it's a germline mutation, in which case we see that mutation in all of your cells, it's very difficult to know where individual somatic mutations came from. But Richard, you're totally right in that some particular sources of mutations have very specific characteristics. So an example of this is mutations in the skin caused by ultraviolet light damage. These have a very kind of specific feature to them. They occur in very specific places on the genome, not with 100% specificity, but enough that if we analyze 100 mutations, you can get a pretty good sense of where these mutations came from, whether it was from ultraviolet light exposure or from other sources. So we do have kind of a crude way of understanding it, but it's very experimental and not something that's really clinically implemented yet.
Thank you.
Well, it's still very, very good. Norm, you had a question?
Yes, I just wanted to follow up on some earlier questions that Cameron answered. The first part of my two-part question is, there was an excellent slide towards the end that showed all of the various gene mutations and possible forms of treatment. At what stage in the at what stage does sequencing reveal these particular mutations in ctDNA? Is this rather late stage of metastasis, or is this are all of these mutations present at the early stage or potentially present at an early stage?
That's also a really good question, and it's something that we're also trying to kind of clarify using our circulating tumor DNA test. So this particular trial that I think you're referencing, this is looking at really late stage prostate cancer. So after patients have progressed on standard of care therapies like abiraterone and enzalutamide, and usually chemotherapy as well. And how this trial works is that a patient will get enrolled, will obtain a blood sample from them and analyze it, and based off of the mutations that we see there, assign them to a therapy arm where the therapy is coupled to the specific mutation we see in their blood test. Now, some of the other work that we've done is for individual patients, we've collected blood samples over many years of their treatment and tried to see how much the tumor biology really fundamentally changes over time. So whether these mutations, if you see them in one sample, do you see them in all samples, or whether they actually change as the tumor develops resistance mechanisms or responds to treatment. And for many of these different biomarkers, they seem to be present in basically over the course of a patient's disease. So this is actually really quite fortunate, because it means if for technical reasons the ctDNA test is uninformative, we can actually reflex or go back and look at their tissue biopsy data as kind of a backup, just in case the ctDNA test doesn't work. So for many of these biomarkers, they do appear to be present early on in disease, and once they're there, they tend to stay there. Of course, that's not true for all of the biomarkers. So one of the things we're trying to do is understand which biomarkers kind of arise later in disease versus those that are present right from the very beginning.
Good. The second part of my question then, there in that slide, there are 8 examples of mutations there. What percentage of the population with metastatic cancer has more than one type of tumor present, would you estimate, or do you know?
So that's also a really excellent question, and it's something that we're trying to basically figure out how to manage. So you're totally right in that the cancer genomes tend to be very complex. They don't just have a single mutation or 2 mutations. They often have hundreds or potentially thousands of these different mutations. And so it can be very challenging in some scenarios to understand which mutations are really driving that tumor. And so our lab and others are trying to develop ways, kind of drawing upon evolutionary theory to understand and prioritize mutations for specific treatment options. So one of the challenges of this trial is that some of these patients had more than one biomarker that would make them eligible for a given therapy. So I know for a fact we had one patient who had one of these AKT1 activating mutations, so they would have been eligible for an AKT1 inhibitor, but they also contained an alteration in BRCA2. And so how do we prioritize which drug is likely to be most efficacious? The patient has both of these drugs. And in this case, we were able to draw upon some additional kind of biological evidence that, in fact, that the BRCA2 alteration appeared to be present in more of the tumor cells than the AKT1 mutation. So what this suggests is that maybe, at least for the first drug the patient should receive, that the DNA or the PARP inhibitor, or in this case, it was a different type of drug, but this green drug here was probably most efficacious as kind of a first option. And then if the patient developed resistance to that, then we knew that the AKT1 inhibitor would be a suitable backup. But it's complex, and that's something that I still think we need to do a lot of work in to really optimize how we dispense these treatments based off of the testing result.
Thank you.
Any further questions? Any further questions?
Yeah, Len, this is Dennis McKintock, an ardently curious soul from Kelowna.
Thank you, Dennis.
And this, I'm a newbie. This is my first time on. But my question to Cameron is that if I was interested in acquiring circulating tumor cell tests. Where would I go to in Canada here, and roughly how much would it cost? I've been after my oncologist for about 2 years, and in writing over 5 times. I'm process engineering was my first career, so I'm interested in biomarkers. I would like to have a bit of an indication in order to characterize my situation. I was a Gleason 9, trimodal treatment for over a year, ADT and high dose brachy and EBRT. And I think after a couple of years, I've finally stabilized in all my side effects. But I'm very interested in tracking this basket of markers. So I have taken it upon myself to track things like, because I found over 50 journal articles on hemoglobin, albumin, LDH, platelets, lymphocytes, neutrophils, FSHs, LH, and PSA and testosterone.
Wow.
And yes, maybe it is a waste of money, but it certainly gives me a lot of comfort, because I wouldn't mind a little bit of warning if things are changing. Also, I would like to say I was a totally asymptomatic patient. I went in for an annual physical. I pushed to have my PSAs done. I pushed to have % free over total and worked out the probabilities that were 70% of a high risk prostate cancer. So then I moved on to urology and urologist, and then the oncologist. So in summary, is there a place in Canada if I choose to pay for the test? And
So
how much will it cost me?
Yeah, great question. So currently, the majority of these circulating tumor DNA tests are administered in usually an academic setting. So I would say probably 70% occur in the context of research studies like ours. But the other 30%, now I might have the details a little bit wrong about this, but there are some commercial tests that your oncologist or urologist can order. I'm not sure whether it's reimbursed by MSP, but nonetheless, these tests are typically between $200 and $600, depending on which one you get. So there's a couple of different tests that I can mention by name. One is called Foundation 1. So this is a circulating tumor DNA test. And then there's another circulating tumor DNA test called Guardant 360. So these are two kind of commercial platforms or versions of this test that are typically used for quite late stage disease. So they're not currently as effective in earlier disease, but if that's something that really interests you, then it would certainly be worth bringing up with your doctor, and also seeing whether it's possible to get one of these tests privately, since they don't cost too much. But yeah, it's a great question, and to be honest, I don't have a kind of a more comprehensive answer. But really, I think the best resource to understand whether these tools are useful is to have a conversation with your doctor about it.
Yeah, I have many times.
Many times, yeah.
Thank you very much for your answer. But the bottom line is, what's your life worth? I had this discussion with my doctor, and gee, you're going to have to pay $20 for a PSA test. Fine. My PSA comes back at 11. I've been taking Avodart for 11 years. And the new conversion factor now is 2.5. So this puts me up into the 20-25 PSA range, which is a lot higher than 8.
Yes.
So to me, I understand that one of the best strategies is earlier is better than later. So I guess my argument is, gee, it would be nice to have the information available if we're into informed decision making and we're into patient-centered care models. Gee, let's get the best information we can. And I understand from a cost accountant and scientific panel point of view, we're only going to pay for certain things. I don't mind paying for information if I think it's going to be useful going forward. and I don't have the need to have immediate treatment associated with my test results. I'd like to follow the trend. Back to the trend is your friend.
Totally, I appreciate that.
But why isn't a basket of markers used? You know, because I've got lots of journal articles. I probably have well over 1,000 all on prostate cancer. I've been busy over the last 3 years, but there has been a lot published on these various markers, and I don't know if you would call them biomarkers, like hemoglobin, albumin, platelets, and LDH, and etc. But they make me more comfortable.
Totally.
From a socio-psychological perspective.
Yeah. No, I appreciate that perspective, and I think I would be much the same way. For me, it's the more information, the better. So many of those blood tests or biomarkers you mentioned are in fact used in routine clinical testing. So LDH, alkaline phosphatase, albumin, just general blood counts. Although typically these are used for later disease because they're also helpful for monitoring, for example, toxicity to chemotherapy. And so, for example, alkaline phosphatase is not such a useful biomarker unless you're actually being treated with chemotherapy, is my understanding. But certainly the two paths to obtaining these tests, if you're interested, are either through your doctor, trying to order one of these commercial tests, or conversely, seeing if there are any clinical trials or research studies that incorporate circulating tumor DNA or other tests into kind of the treatment paradigm. And these are sort of the two, I suppose, most convenient avenues to get your hands on this information if it's something that you feel will be really valuable.
Thank you very much. No, I have contacted some of the commercial labs, but they won't talk to me unless, you know, my primary caregiver talks to them. Yeah. Anyway, thank you very much. I really enjoyed your presentation. Learned a lot.
Oh, my pleasure. The last comment I was going to say is that I might be wrong on this, but I think your next meeting you're having Dr. Lucia Nappi speak with you, and I've worked with her before, and she's a medical oncologist and routinely kind of administers these tests and similar tests to her patients, and so she would have a much more precise understanding of how to kind of for the average patient, how to get one of these tests. I'm only a PhD student, so my understanding of this is a little bit more limited, but I think she might be able to provide some more specifics.
Thanks for the heads up. Great motivation for the next meeting.
No problem.
Cameron, you're being very modest. We have another question here, Norm. You have another question?
Sure.
No, I didn't take my question down. I'm sorry.
Okay. I just want to say, Cameron, you've made this very complex, understandable. This situation so difficult to understand, so complex, and you made it possible for us to understand. Terrific job. Terrific job.
Well, thank you very much. And again, it was a real honor to be able to speak with you. And the final thing I'll mention is that if anyone has any sort of follow-up questions that they didn't get an opportunity to ask here, or questions that arise later, Norm and Len, if you're willing to pass on my email address, I'd be more than happy to answer any questions via email as well. Again, I'm very glad for this opportunity to speak, and I'm glad that you found it useful.
Cameron, thank you very much. We'll keep we actually have your name, so we'll be able to communicate any questions we can. We'll certainly pass them on to you. So
perfect. Sounds great.
Thank you very much for being with us and sharing your vast knowledge about this very complex problem. Yeah,
thank you very much again.